means that the patient still meet the criteria to use BiPAP, right? If the patient CO2 is still high after 2 hours, so you need to wait. So some patients require longer time to wash out carbon dioxide. Okay, so if you see that 2 hours later, CO2 still high, not improved, you need to let the patient wear the BiPAP. Usually we wear overnight. Okay, and you need to think about that. Maybe you need to adjust the strap. Maybe it's a lot of leakage. Maybe it's a patient fighting to cause the poor wash out of carbon dioxide. Okay. Okay, so the next things I will talk about invasive mechanical ventilation.
I want you to the slide for contraindication. And hi, I'm Dr. O, and I'm very honored to have I just want to share a little bit about how we manage the contraindication. Sometimes I know in here we are very afraid of contraindication and adverse effect of non-invasive ventilator. But what we need to know, when we are doing ACLS, every concept is the same. Not only doing ACLS, when we treat our patient, what's the priority? A, B, C, D, E, right? First is airway, breathing, circulation, and then is other. So sometimes we see like a patient has copious or vicious secretion. This is relative contraindication. A patient on BiPAP, can we still use it? So how do we assess? We assess A, B, C, D, E. Can the airway be maintained? If the student is really too aggressive and too copious, maybe not. But if it's acceptable and it requires this for oxygenation and acidosis, we still need it. And for the fixed nasal pharyngeal, abnormality, and the extreme obesity, we also think the same way. We think about can we tolerate, and there are something we might want to stop an IPVV like what? Vomiting, right? So what do you do with vomit, and what is the harm of vomit? The harm of vomit is you might get aspiration, but how do we balance the risk and benefit? The patient is having acidosis and he's having nausea and vomiting. If the nausea and vomiting is persistent, you cannot fix it. Then of course you might need to intubation. But when intubation is not possible and the patient is still in severe acidosis, what do? We do NG decompression. And if it's still, and we give metoclopramide or we give Novomin to stop the nausea and vomiting, but you should still use because why? A, B, C, D, E, the breathing is the most important part than others. So I want you need to know the priority. There are some contraindications and some complications will happen, but the priority is respiratory acidosis because the patient will die very fast from that. So we need to know the priority. Okay, thank you. Do you have any question?
For how long the patient can be on CPAP or BiPAP? Is there a time limit other than filling the ABG?
Time limit.
You mean to evaluate?
Yeah. For how long can the patient be on CPAP?
It can be, patient can be very long, like 2 to 3 weeks old. Sometimes in very severe patient, we give it 2 to 3 weeks, but we will try to wait. Yeah, so for prolonged IPVV, the bad thing is it will sometimes come compression pressure. It will cause some ulcer in the face, just like in bad show, but it was on the face. So that is the contrast. That is sometimes we don't want to use it for too long. But for acute stage, I think use like 4 hours and we will evaluate. If it's still not effective, we might try to intubate. But when intubation is not possible in your facility, despite still respiratory acidosis, I think BiPAP is still better than non-rebreathing mask. Yeah, is that your question?
Yeah, so every things have indication and contraindication. So you need to assess the benefit and risk. If the benefit is more than risk, and you can use it. Okay. So the next part. Here. So next part is invasive mechanical ventilation, but the concept is the same. They have indication to use invasive mechanical ventilation, and also invasive ventilation can also cause some problem. Okay, but you need to assess the risk and benefit of that. Okay? So the first is the mode. Invasive one is more complicated than BiPAP or CPAP. And later we have a workshop, and we will talk about one transport ventilator, and they have this mode. And I will demonstrate to you how to use that mode. Okay. So for this part, I just brief introduction about each mode. Okay, so the first mode is the continuous mandatory ventilation, or we call CMV. And they have PCCMV or VCCMV. PC means pressure control. VC means volume control. Okay, so pressure control means that the important thing is pressure. So you deliver constant pressure to the patients. So we need to set a pressure level, inspiratory pressure level over here. And you see the same rectangle over here. And the pressure should be constant, okay, so in each breath. And next thing is the same, is the PEEP level. So it's similar to BiPAP. We have EPOP and IPOP, but in invasive one, we have PEEP and we call PIP, peak inspiratory pressure. But the function is the same, okay? And the second thing we need to set is inspiratory time. So we need to let the ventilator know that in each breath, how long should ventilator give this breath, okay? And another thing is respiratory rate. So it means that in 1 minute, the ventilator required to deliver this positive pressure, and how many times the ventilator required to deliver. So if the respiratory rate we set 10, for example, means that in 1 minute we will see 10 this dark green rectangle over here. And because this is CMV mode, so all the breaths are delivered by time. So this is time trigger, which is independent of patient's triggers. And another thing is FiO₂, because we need to expand lung first to improve the shunt, and then oxygen go inside. So we will give the FiO₂s concurrently. And another is volume control. And volume control means that the important thing is this mode deliver constant tidal volume to the patient, not the pressure, okay? In pressure control, we deliver constant pressure. In volume control, we deliver constant volume. So we deliver constant volume to the patient. All things is similar to pressure control, so we still need to set a PEEP label. And inspiratory time, also respiratory rate. And because this is CMV mode, so all volume controls are triggered by time. Okay, it's a time trigger. And next thing is FiO₂ is the same. But if you look at the waveform over here, the below waveform, this is a volume time curve. Above waveform, this is a pressure time curve. And at the middle, over here, this is a flow time curve. And you can see the difference over here. In pressure control mode, the flow time curve is like this shape, this triangle shape over here. But in volume control, the flow time curve is like a square shape. Means that in volume control, the flow is constant as well. Okay, because this equation, tidal volume equals to inspiratory time times flow. But because you already set tidal volume, right? You already set this value. And also you already control inspiratory time. So it means that you also control the flow. Okay? So the flow is constant. So this raises another issue. If the patient, for example, like this one, the flow is constant around, maybe this is 40, this is 60, so maybe now the flow now is 50 liters per minute. Okay? So you deliver 50 liters per minute of constant flow to the patient. But now, if the patient has sputum obstruction, feel dyspnea, and the patient will increase vocal breathing, right? So the patient will try to increase the flow. Maybe the patient required to use 60 to 80 liters per minute of flow. But now, if you use volume control, you give the constant pressure, constant flow, and this flow just 50. So it's not enough for this kinds of dyspneic patient. Do you know what I mean? The patient now requires 60, but in volume control, you just deliver 50. So this flow is not enough for the patient. Okay, so the patient will feel more dyspnea, and this is what we call flow asynchrony or flow starvation. It means that your flow is too low to the patients. Okay, but in pressure control, the flow is variable. So if the patient try to breathe in more fast, this mode can increase the flow simultaneously because the flow is not constant under pressure control. So during this acute condition, usually we use pressure control instead of volume control due to the flow pattern. In pressure control, the flow is variable. It depends on the pattern, breathing pattern of the patient. But during volume control, we fix everything. Okay. But if the patient is stable, both modes are fine. You can use volume mode or pressure modes are fine. Okay. So this is to give you an example. In SIMV mode, all breaths are time triggered and mandatory. Mandatory means that you deliver either inspiratory pressure, constant inspiratory pressure, or constant tidal volume. So if we set a respiratory rate around 12 breaths per minute, and patients has 20 breaths per minute of spontaneous breaths, because these modes just can trigger by time, so the ventilator can just deliver 12 breaths of mandatory breaths independent of patient's trigger. Okay. And next is assist control. And in assist control, all the things is the same. In PCAC, you need to deliver constant pressure. PEEP, you need to set PEEP level, inspiratory time, respiratory rate. But the difference is this one. In assist mode means that these can sense patient's trigger. So each mandatory breath can be triggered by time or patient. So you need to set not just FiO₂, you need to set a trigger label, pressure trigger or flow trigger. And later in your workshop, that ventilator can just have pressure trigger, okay? And in volume control assist mode, it is the same thing. You need to set constant tidal volume to the patient. You need to set PEEP, inspiratory time, respiratory rate, and the trigger is by time over patients. So you need to set a FiO₂ and trigger label. And the same things because this is a volume control, so the flow is constant. Okay. So for example, in AC mode, you set a respiratory rate around 12 breaths per minute, but the patient had 20 breaths per minute of spontaneous breaths. The ventilator, because now the ventilator can sense the trigger from the patient, so now the ventilator can deliver 20 breaths of mandatory breaths. Okay. Is that clear for you? Differentiate CMV and AC. Okay. But if the patient's respiratory rate is below 12, if you set the respiratory rate around 12, and patients just have 6 breaths per minute, the ventilator can still deliver 12 breaths. And these 12 breaths includes 6 breaths by time trigger and 6 breaths by patient's trigger. Okay, so it means that at least you have the 12 breaths per minute. Okay. And another mode is pressure support mode. And this mode is that the target is the same, like a pressure control. The target is the pressure support label. So you need to set a pressure support label. So it delivers a constant pressure to the patients. Okay? And usually the pressure support label is lower than pressure control label because if you like to use pressure support mode, it means that the patient, we try to wean the patient. Okay? And next is that the PEEP, we need to set a PEEP label. And in pressure support, the difference from control mode is that all the breaths are patient's trigger. Okay, so it means that if the patient has apnea, you cannot use pressure support. So that's why pressure support, we use the pressure support in weaning mode when we try to wean the patient. Okay. So we need to set the FiO₂ and trigger level, and you need to remember these important things. All the breaths are just triggered by patients, not by time. But because we don't need to set the respiratory rate, we don't need to set inspiratory time. So how can ventilator know the inspiratory time of the patient? So in pressure support, they use different settings they call flow cycle. They use this different method to cycle the inspiration. So flow cycle means that during inspiration, the flow will increase first and increase to this is called peak inspiratory flow, PIF. Okay, increase to this part. And after that, the flow will, if our flow cycle set 25%, is a percentage, we can set from 25 to 50%. And if we set 25%, it means that when the flow, inspiratory flow, decrease to 25% of peak inspiratory flow, the ventilator will cycle to aspiration. So this is flow cycle means, okay, decrease the flow, increase the flow first, and then decrease to the percentage you set, and then shift to aspiration. Okay. So in pressure support, we don't need to set inspiratory time. We just need to set flow cycle to determine the inspiratory period. Okay, so in pressure support, all breaths are patients triggered only and is spontaneous. Okay, so we need to set a pressure support label. So patient had 20 breaths per minute of spontaneous breathing, and ventilator can deliver 20 breaths of pressure support. Okay, and another mode is SIMV mode, but I shift a little bit. I put SIMV next to the pressure support because you already know the control mode. You already know the support mode. SIMV is combine these two. Okay, so SIMV means that they have some part relate to control mode and some part relate to support mode. So you need to set inspiratory pressure in PC SIMV with pressure support. You need to set inspiratory pressure, PEEP, inspiratory time, respiratory rate, and this can be triggered by time or by the patient. Okay, and also FiO₂ and trigger label. But you also need to set the pressure support label. And when you set the pressure support label, you need to set the flow cycle. So you just combine the control mode and support mode. Okay, so you can imagine that during our weaning process, we can shift the patient, shift the mode from control to SIMV because SIMV is combine both control and spontaneous mode. And then if the patient can tolerate SIMV, you can then shift to pressure support. Okay. So in VC SIMV is the same thing. We need to set the tidal volume, constant tidal volume, and all the thing is the same. And we also need to set the pressure support label and also the flow cycle. So it's a combined volume control with pressure support. Okay, so for example, if we set the respiratory rate around 8, okay, and patient has 20 breaths per minute of spontaneous breathing, it means that in SIMV, the ventilator will deliver 8 breaths of mandatory breaths. So this 8 breaths is similar to control mode. And another 12 breaths is similar to pressure support mode. So this combines these two, okay, 8 breaths of mandatory breaths and 12 breaths of spontaneous breaths. Okay. Okay, so this is just a brief introduction about the mode, and next is indication to use invasive mechanical ventilation. But I just list some part. I like to emphasize again, this is not a fixed criteria. This is just for you, just a concept for you to assess the patient. Okay, so if the patient have CO2 problem, ventilatory problem, CO2 retention, oxygenation problem, decreased oxygenation, and usually if we use FiO₂ more than 50 to 60%, but PaO₂ still low, 60 to 70 mmHg, it means that this is refractory hypoxia. So you need positive pressure to re-expand the lung first. Okay. And another criteria is the tidal volume and respiratory rate. Some patients increase vocal breathing and have rapid shallow breathing. Means that the respiratory rate is high and the tidal volume is low. So it's a rapid shallow breathing. And mini ventilation sometimes is high. So this is another indication to use invasive mechanical ventilation. But not just from oxygenation and ventilation, sometimes is the conscious of the patient. So from GCS, Glasgow Coma Scale, you need to assess the patient. If the patient has poor conscious due to maybe car accident, and the conscious level is lower than 8, the Glasgow Coma Scale, means that the patient don't have ability to protect their airway. Okay, and Dr. O already said that we need to put A first, right, airway. So this is another indication to use invasive mechanical ventilation to do intubation, or some patients require tracheotomy too. Okay, and the next part is just initial setting, but initial setting, the same thing, it's just a range, it's just acceptable range, and you can adjust according to your patient. So you like to set the tidal volume, usually around 6 to 8 ml per kilogram of ideal body weight. And in severe asthma or ARDS, acute respiratory distress syndrome, we need to protect the lungs. And usually tidal volume would be decreased a little bit from 4 to 6 ml per kilogram. And for inspiratory pressure, you can start from 10 to 15 and increase or decrease the pressure to target your tidal volume around the same, 6 to 8 ml per kilogram of ideal body weight. And the pressure, if you use a pressure control or pressure support, because you need to set the pressure level, you need to keep these things, the throttle pressure less than 82 to 30 centimeter water to prevent barrel trauma. Okay, ventilator, positive pressure induced lung injury. Okay, and what is throttle pressure? I don't want to talk detail about this throttle pressure, but I just want to give you a concept. Now you can breathe in. When you breathe in, and then hold a breath, and now your lung have pressure. This pressure we call throttle pressure. Okay, when you breathe in and hold a breath, and your lung, the pressure inside your lung now is throttle pressure. Okay, so we should keep this pressure below 28 to 30 centimeter water. Okay, so I just skip the scale over here. Okay, and another setting is respiratory rate. You can just use normal respiratory rate 12 to 20, and we usually set 12, 14, or 16. Inspiratory time is a range 0.8 to 1.2, and keep inspiration and expiration ratio around 1 to 2 to 1 to 4. Okay, and I will show you this parameter later during our workshop. Okay. And you can set a PEEP value over here, FiO₂ over here. And FiO₂ should not be high, because I saw in your ICU, the first patient comes from emergency department, and you set FiO₂ 70%, but that patient is normal lung. So usually you can just start from 40 to 50%, and according to the saturation to do titration. So saturation should be keep maybe for critical illness, usually around 92 to 96. For ARDS, 88 to 95. For COPD, a little bit lower, 88 to 92%. Because oxygen can have side effect toxicity. Oxygen toxicity, they can generate free radical and cause lung injury. So we need to use minimum oxygen level to target our saturation. Okay. And next is sensitivity. I already talked about this part. For trigger 2 to 3, pressure trigger -1 to -2. Okay, and next is if you try to shift mode from control mode to SIMV or to support mode. Usually the setting in SIMV or in support, pressure support, is lower than the control mode because you try to wean the patient. Okay, so the pressure support level we usually just use 8, 10, 12 over 14, usually less than 20 centimeter water. Okay, and flow cycle I already said it. We need to set during pressure support mode. And SIMV rate we usually set lower than normal respiratory rate. So we usually set 10, 8 or 6 breaths per minute. FiO2, the same things, usually lower because we try to wean the patient. If the patient still required to use high FiO2, what does that mean? What does this mean? If the patient required to use high level of FiO2 during SIMV or during pressure support, it means that the patient, this is not the time, this is not a good time point to wean the patient, okay? Okay, and this is just equation for you to calculate ideal body weight because we need to set the tidal volume according to ideal body weight. And you can just search online, they have a lot of equations, but I think all of the equations are fine, okay? All of the equations you can use. Okay, and another setting is alarm setting. And this alarm setting, I don't want to talk about much about this alarm because this is just a fixed setting. And during our workshop, I will directly demonstrate you how to set the alarm, okay? Okay, and the next thing is that if the patient have oxygenating problem under invasive mechanical ventilation, and which parameter you can adjust or which things you need to do. So the first is that if the patient deoxygenated, you can adjust FiO2. I think all of you already know that. So usually we change FiO2 instead 5 to 10%, increase or decrease. Decrease saturation, just increase FiO2 5 to 10%, and to check the saturation again. And if you like to assess arterial blood gas, usually when we change the setting, usually we wait at least 20 to 30 minutes. Okay? And usually in patients, sometimes longer than that. So in our hospital, I always talk to the doctors and that I already changed the setting. And if you would like to check arterial blood gas, maybe wait for 1 hour. Okay, to recheck arterial blood gas. Okay, and this is just estimation. But this is for normal people. If you increase 10% of FiO2, PeO2 should be increased 50 to 70 mmHg. But it's not. Sometimes it's not for the patient. Sometimes I increase the FiO2 10%, but PeO2 just increase maybe 20, maybe 30 mmHg. Not much. Not 50 to 70. Okay, and another way you can do is to expand the lung. If you increase FiO2, but saturation is still low, means refractory hypoxia. So you need to add some pressure to expand the lung first, to improve the shunt first. So sometimes you need to increase PEEP to improve oxygenation. So some disease like this disease, pulmonary edema or ARDS, frequently to cause lung atelectasis or lung collapse, to cause shunt. Okay, so that's why they cause refractory hypoxia. And another way is that if you increase FiO2 a lot, but PaO2 is still low, means that this is another indicator to see refractory hypoxia. Okay, so this is indication of PEEP. And contraindication just one. Absolute contraindication just tension pneumothorax. Okay, if the patient have pneumothorax, untreated tension pneumothorax, we usually tend to turn the PEEP down to 0. And after chest tube insertion, we can return the PEEP back. Okay, so just this contraindication. The other thing just relative contraindication. So I need to memorize just one. Tension pneumothorax, untreated tension pneumothorax. Okay, and another thing is that you can adjust FiO2 or PEEP to improve oxygenation. And another way is to just change the position. So for example, the normal lung is here. Okay, this side of lung is normal. So I use laser. This side is normal, so the ventilation is normal. And this side is abnormal, so the ventilation decrease. But the perfusion is gravity dependent. Okay, so when the patient, the position like this, the perfusion will be like this way. Okay, so in dependent region, the perfusion is higher. In non-dependent region, now is normal lung, the perfusion is low. So this is called VQ mismatching. Okay, but when we change the position, upside down. This is called good lung down. Okay, good lung down. So we put the normal lung in dependent region to improve ventilation, but the perfusion is still gravity dependent. So now, large V in dependent region and large Q, large perfusion still in dependent region. So this is called NICU matching. And this non-dependent region, we can see the ventilation is poor, but perfusion is still poor as well. So this is another NICU matching. Okay. So sometimes we just put good lung down to improve oxygenation. Okay. And another thing is that these things, most of the situation is that you not suction, you don't suction the patient very often, cause sputum accumulate in the lung and cause desaturation. So the most important thing is that you need to do chest care and add humidification. Or sometimes it's bronchospasm, you need bronchodilator therapy. Okay, and another thing is CO2 problem. And I think this part you already know that increased CO2 production, like the agitation, pain, or overfeeding, and this can increase CO2 production. And decreased CO2 production include the sedation, sleep, or paralyze the patient. And if you'd like to adjust the setting to improve ventilation, these two parameters, tidal volume and frequency. So I give you this is from our respiratory care textbook. If the patient under volume control, you can increase tidal volume to wash out CO2 or increase respiratory rate. Okay, and under pressure control, you can increase pressure level or increase respiratory rate. But you need to remember this part. After adjusting tidal volume, the setting, you need to keep the throttle pressure less than 30 centimeter water. Okay, and I think this is the final two parts. The first part is the troubleshooting, and I just give a brief introduction about how did you do to deal with the troubleshooting you solve the problem, desaturation, or alarm. Okay, the order is that you need to check the patient first. Okay, so you need to use your stethoscope to assess the patient. And next is to look at go upstream to look at artificial airway, or in BiPAP you look at the mask. Okay, and if you don't find any problem, go further upstream to look at the ventilator circuit, maybe some sputum accumulate in the circuit. And finally is to look at ventilator, some problem with the ventilator. Maybe oxygen cylinder is already empty, or maybe it's loss of power. Okay. So the common alarm is that the first is high pressure alarm. So you need to check the patients first. So most of the condition is related to secretion, obstruction, and cause high pressure alarm. So you need to do suction. And sometimes it's bronchospasm. So you need to use your stethoscope to differentiate. It's a precold, it's a breathing, the breathing sounds. And if the patient has bronchospasm, maybe you need to give bronchodilator therapy. And sometimes the patient just cough, and you can just wait till the patient is stable. And sometimes it's ventilator asynchrony, means when the patient tries to exhale, and the ventilator deliver a tidal breath simultaneously. So exhale gas and inhale gas collide each other and induce high pressure alarm. And you can adjust respiratory rate according to patient's recent respiratory rate, or you just switch on trigger function, okay, to let the ventilator sense the trigger by the patient. And next is artificial airway problem. So sometimes it's the secretion obstruct in artificial airway or accumulate in the mask. And sometimes it's kinking of endotracheal tube, and usually is the patient bite the tube. Okay, and if the patient bite the tube, you need to insert oropharyngeal airway, or what we call oral bite block, beside the endotracheal tube. Okay, to prevent the patient bite the endotracheal tube. And another thing is the endotracheal tube migration distally. We call one lung intubation, because sometimes you change the position, you move the patient, and the endotracheal tube move deeply into the lung. And this called one lung intubation and can cause high pressure alarm. So you need to check the mark on this part and do repositioning. And during our workshop, we will let you do that. Let you check the mark of endotracheal tube. And next problem is about the ventilator circuit. Maybe some secretion, water, blood accumulate in the ventilator circuit. So you just disconnect it and do the suction and reconnect it. Okay. And sometimes it's kinking of the tubing. Okay, obstruction in the tubing. And sometimes it's a malfunction of respiratory valve. So maybe you need to change to another ventilator, another circuit. Okay. And I like to focus on this part. If you don't find any problem, or you don't know the problem is, but the patient still have distress, respiratory distress, desaturation, you can just directly disconnect the patient from the ventilator and use resuscitator to manually brace the patient. And you need to connect the oxygen tube on this resuscitator, okay, and connect with the oxygen cylinder, okay. Okay. And another common thing is low pressure alarm. But low pressure alarm, you just focus on one thing, is disconnection. Sometimes it's leakage, disconnection or leakage. So sometimes it's leakage from in the lung. So maybe the patient already has fistula or pneumothorax, so leakage from that part. Okay. And if the patient has airway problem, sometimes it's the leakage from a mask if you use an IV, or leakage from the cuff of endotracheal tube. So you know that in our endotracheal tube we have a cuff over here. Okay? So sometimes it's a cuff deflection, so you need to re-inflate it. So later we have one workshop talk about caring of ventilator patient. We'll let you use syringe to re-inflate the cuff. Okay? And sometimes it's endotracheal tube migrate proximally, means that endotracheal tube move out already. Okay, so this causes leakage, high leakage, and you need to reposition. Okay, and cuff rupture, the same thing. You need to change another endotracheal tube. Okay. And other thing is related to ventilator circuit to cause low pressure or low volume alarm is disconnection, so you just reconnect it, or sometimes it's tube rupture, malfunctioning, and you need to change to another tubing. And the same thing, if you cannot find any problem, but the patient still has respiratory distress, you can just disconnect the patient and use manual resuscitator with oxygen cylinder. Okay. Okay. So another troubleshooting I like to focus on is this part, because this is your patient in ICU, and I solved this problem, so I recall it. Okay, so you look at this waveform first. This is volume control. Okay, but the pressure, you can see that the pressure is like this, is like the triangle over here. So this pressure is good. Okay, but how about this part? The pressure is weird, right? They have two peaks over here. Okay, and the flow is constant. The second one is flow is constant. Okay, but do you see the difference about the flow? Some problem with the flow. The flow is shaking. Why? Exactly. So this problem is I think I recall this one. Okay. Did you see the shaking of the tube? Okay. So remember these things. Okay. If you already see the shaking of the tube, means that they have a lot of water inside the tube. You need to drain out. Okay. And sometimes it's the secretion in the airway, and you need to do suction. Okay. So later I will tell you how to drain the condensed water within the ventilator circuit and how to do the suction. Okay. And the final part is that I just want to talk about one thing, concept for you, is the weaning. If you try to wean the patient, usually if you try to start weaning, the first is minimize sedation, okay, and let the patient early mobilization. And from ventilator setting, we can shift from a control mode to SIMV mode and to pressure support mode, and this is called gradual weaning. Okay, and finally is we call a spontaneous breathing trial, SBT. Okay, but if the patient, this is called gradual weaning, but if the patient is normal lung, just post-operation, maybe the patient has car accident and has head injury, and after operation, you can wait till the patient is awake. Okay, if the patient is awake, you can directly extubate. Okay, because that patient is normal lung. So some patient, if the patient is normal lung or young age without any comorbidity, sometimes we can extubate earlier. So this is what we say over here. Usually in our hospital, for some post-operative patient, we extubate the patient within 3 days. Okay, some patient just after operation and the patient wake up, we extubate it. Okay, but some patient have a lot of comorbidity, lung disease, ARDS, pneumonias, or COPD like this. And if the patient is like this, if the patient have a lot of comorbidity or high age, sometimes we need gradual weaning. Okay, and the gradual weaning means that if the problem already resolved, the underlying disease of the patient already resolved, we can shift the mode from control to SIMV to pressure support. And then we can see some measurable criteria I will show you later. And if the criteria is stable, means the vital sign is stable, arterial blockage is stable. And then if you are not sure the patient can extubate or not, you can do spontaneous breathing trial, SBT. And I will talk these things later. Okay, so the flow, the protocol is like this one. Shift the mode, look at the criteria, and then if not sure the patient can extubate or not, you can do spontaneous breathing trial. Okay, but for post-operative patient, sometimes we just extubate immediately after the patient wake up. Okay, so this is some measurable criteria, but I just focus on part you can measure in your hospital. So if the mini ventilation is low, okay, tidal volume is high, respiratory rate is low, means that the patient don't have rapid shallow breathing. Okay, so this means that the normal condition, right? And also the oxygenation, your FiO₂ use below 40%, but the saturation is still good. Saturation is still more than 60 mmHg. And your PEEP safety, because PEEP can affect your oxygenation. PEEP you use just low, 5 to 8, means that the patient can tolerate low setting, so you can go further to your weaning process. Okay, and another criteria is related to hemodynamic, but I don't want to talk about too much about the cutoff value. Okay, it's not a fixed criteria, but you need to consider ventilation, oxygenation, hemodynamic, underlying disease, or even conscious. If the patient, all the things are stable, you can start your weaning process. Okay, and if you are not sure the patient can extubate or not, can disconnect the ventilator, positive pressure ventilator or not, you can do this. This is called spontaneous breathing trial, but it's just 30 minutes to 100 to 2 hours. Okay, and it said that almost 70 to 80% of patients who pass this spontaneous breathing trial can be successfully weaned and extubated. And the method is that you can use low label pressure. Okay, and low label pressure means that low label CPAP 0 to 5 centimeter water, or low label pressure support from 5 to 8 centimeter water, or TPEEP trial. And TPEEP trial, I'm not sure whether your hospital have this or not. This is just connect the humidification over here and connect to the large tube and connect to this T-shape adapter and connect to the endotracheal tube. Okay, so it means that it just deliver oxygen therapy without positive pressure. Okay, so this oxygen therapy connect to endotracheal tube patient. Okay, so you can use these 3 methods for about 30 minutes to 2 hours. And after that, you can check the vital sign, check the hemodynamics, and and check the arterial blood gas after 2 hours of spontaneous breathing trial. And if the patient passed these things, and you may consider the next step is extubation. Okay. So I skip this part. The final part is extubation. I like to focus on one important thing is that weaning is not equal to extubation. Okay, this is very important things. Weaning is not equal to extubation. Some patients still require ventilator, but just low safety. For example, like neuromuscular disease. Maybe they have poor muscle force. Okay, so they still require ventilation. But sometimes neuromuscular disease, they have just neural or muscle problem. Their lung is normal, right? But these kinds of patients, because these kinds of patients require ventilation, so they can wean it. We can wean these kinds of patients. But sometimes these kinds of patients cannot extubate it. They require ventilation. Okay? So, and also some patients with poor conscious, they have poor cough reflex. They cannot protect their airway very well. So sometimes these patients can be weaned, but cannot extubate. Okay? So if we try to extubate a patient, we need to see this part, airway patency, and to check whether the patient have enough cough reflex or not. Okay? To check whether the patient has ability to protect airway. Okay? If the patient has ability to protect airway, the next step is that we can extubate the patient. If the patient cannot, for example, like poor conscious, sometimes we suggest tracheotomy. Okay? So in Taiwan, we have a lot of patients have stroke or have head hemorrhage, and after operation, their conscience is still poor. And so it means that these kinds of patients cannot protect their airway very well. So when we extubate the patients, this can cause aspiration. Okay? So for these kinds of patients, because we know that the patient requires use ventilator for a long time, so if we estimate that if the patient needs to use ventilator more than 7 to 14 days, we will give this is called education sheet, tracheostomy tube education sheet for the patient and for their family members to consider tracheostomy. Okay, so this is another thing. Means that the patient can be weaned but cannot extubate, and we will shift to tracheostomy. Okay, so sorry about a little bit delay. Any question? I think some part you just first time to hear. So I think later we'll have workshop in each stop, and I think after workshop you will be more familiar with the concept of mechanical ventilation. Okay. Okay, and if you have question, you can ask me individually or ask me later.